Thank you for the kind introduction and good afternoon to all of you. So for the next 20 minutes or so, we will be discussing the what, why and how of the pre-operative thyroid fitness. So we will be trying to find out the answers of these three questions: the why to optimize pre-operatively, whom to optimize, and how to optimize. So the relation between thyroid and heart is known maybe long back since 1786 when Perry described the women with goiter and palpitation. And we know that the thyroid hormones have their action in almost all systems of the body, and it is mediated through thyroid hormone receptors, either alpha or beta. And every day we receive the call from our surgery or gynecology colleagues regarding this type of cases: 48-year-old women having abnormal uterine bleeding, detected to have fibroids, who is known hypothyroid on levothyroxine of 50 microgram, and scheduled for a total abdominal hysterectomy with bilateral salpingo-oophorectomy, and now detected to have a TSH of 11 microinternational unit per ml, and who is TPO positive. So, what are the cardiovascular relation of thyroid dysregulations? And due to the genomic and non-genomic responses of thyroid hormones, it can have effect on cardiac output, peripheral resistance, lipid parameters, and consequent coronary health. And dysrhythmias and sudden cardiac death may also be associated with thyroid dysregulation. And hypothyroid patients may have a decreased cardiac output to the tune of 30 to 50%, having increased peripheral resistance. And despite having an adequate catecholamine levels, they may have a decreased adrenergic tone due to downregulation of beta-adrenergic receptor. And because of the low baroreceptor responsiveness, they may have hypotension while being on anesthesia. Regarding coronary artery disease, the relation is through the decreased LDL receptor and hypercholesterolemia, leading to atherosclerosis with the contributing factors like hypertension and, of course, some impairment in coagulation. However, this hypercholesterolemia is reversible both in overt and subclinical hypothyroidism. Earlier studies have shown that there is an increased risk of post-operative atrial fibrillation in cardiac surgery, those who are subclinical hypothyroidism. However, this recent meta-analysis, which evaluated the clinical outcomes after cardiac surgery in subclinical hypothyroidism, they have found that compared to euthyroid patients, patients with subclinical hypothyroidism had higher rates of operative mortality, prolonged hospital length of stay, and a higher rate of renal complications. However, no significant differences in terms of ICU stay or post-operative atrial fibrillation or use of IABP. So, conflicting results are there in terms of post-operative atrial fibrillations in cardiac surgery in hypothyroid individuals. Now, from anesthesia point of view, enlarged tongue, relaxed oropharyngeal tissues, large goiter or obesity may pose difficulty in intubation, and because of the decreased hypoxic and hypercarbic ventilatory drive, the patients may be increasingly sensitive to the sedatives. Impaired respiratory muscle function or impaired surfactant production may lead to increased risk of postoperative atelectasis. And because of glycosaminoglycan deposition and accompanying hypoalbuminemia, effusions are not uncommon. And of course, hematological abnormalities like anemia and thrombocytopenia have been found to be more in patients with hypothyroidism. Other possible complications are acquired von Willebrand disease, hyponatremia due to several reasons like increased ADH or decreased ANF or decrease in RAS activity. Paralytic ileus and gut wall edema are also common. And last but not least, the decompensated hypothyroidism or the life-threatening complications of myxedema coma. So how to approach to a pre-operative patient with hypothyroidism in case of elective surgery? Best to optimize prior to surgery. In adults, we can supplement with levothyroxine at the rate of 1.6 microgram per kg. Except in elderly or those with known coronary artery disease, they should be started with the initially low dose like 25 to 50 microgram daily, with a plan to increase every 2 to 4 weeks until a thyroid state is attained. For people aged more than 70 to 80 years, they should be started with a low dose with gradual up titration. For pediatric age group, the doses are usually age-based. And for subclinical hypothyroidism, we usually treat with a lower dose, and if there is as well risk of cardiovascular disease. So, if we look at the studies which have compared the hypothyroid with euthyroid patients for in mild to moderate hypothyroidism, unlikely to pose any serious adverse outcomes. For non-elective surgery, does not require to be postponed, or it is not necessary to postpone elective surgery in mild to moderate hypothyroidism, because in terms of outcomes of anesthesia or surgery, there is no significant difference. So if you look at